Hello play therapists, supervisors and trainers. My apologies for not being with you live on this call today. Thank you for being examples of the way that we understand child trauma, that play therapy helps previously unprocessed and unarticulated events to be worked through into a place of self-growth and health. Thank you for your contribution to the play therapy profession and for championing our cause to provide therapeutic help to children who need it, through therapeutic models that best suit them, delivered by qualified practitioners. As you know well, we continue to campaign for play therapy to be recognised as a vital part of therapeutic support for children. On reading the new literature about mental health leads in schools, we want to keep explaining the necessity for different therapeutic approaches to be available to children and young people to meet varying needs in varying ways. An argument which makes sense due both to the widely differing age bracket encompassed in this population and due to the distinction between referral criteria which is being made in the literature. With this bit of talking from me today, I send 2 briefing papers for you all to use as resources for any lobbying or contact making that you make. I hope that it will be helpful to have all the most up-to-date information at your fingertips, ready to use in replies or first contacts. Today, we heard of the tragic death of Sir David Amess, the Member of Parliament who made the very first live mention of our Child Mental Health Charter in the House of Commons during May 2019's Mental Health Awareness Week. He raised our argument of revisiting the 1983 Mental Health Act to prioritise supporting children and young people. On that day, he quoted the figures published at the time that 1 in 10 of the youngest citizens had a mental health issue. New figures this week reveal that mental ill health among children in England has reached unprecedented levels, revealing 1 in 6 had a probable mental disorder over the past year. NHS Digital calculate that during the last year, 17% of 6 to 16-year-olds had a probable mental disorder. The article calls for investment in the mental health workforce serving children and young people, much in line with what PT UK have been calling for with our Child Mental Health Charter. It seems to me that with every month that passes, the need grows, and we are so grateful to Sir David Amess and to every Member of Parliament who helped shine a light on our work. So what are we championing? We all know our Child Mental Health Charter and its 6 goals, that any child who needs therapy should have certain access to it, that all therapists should be registered with an independent government-approved agency such as the PSA to protect children, that the government would invest in a qualified mental health workforce, that evidence from on-the-ground practice should inform policy, that parents and carers be best supported, and that joined-up working across agencies concerned with child welfare be prioritised. You'll also know about the early day motion tabled by Dr Lisa Cameron MP for us in September. This calls for play therapy to be a funded part of mental health support in schools and in the COVID-19 recovery programme. We also sent out 3 questions drafted for anyone to send to their MP, requesting that they table them as oral questions when the House of Parliament reconvenes on the 18th of October. They're included in the first briefing paper sent today and grow from the EDM that asks primarily, are the rights of children to a qualified therapeutic practitioner, such as a play therapist, going to be part of the new mental health legislation? The 3 questions and the rationale behind them lay out what is needed for providing help to children who need it. We're responding to this need being widely reported and having worsened since the pandemic. We're responding to findings that early intervention is economically beneficial, as well as, of course, ending suffering for our younger citizens earlier than if help is only provided later on. We propose that if early intervention is both sensible and kind, what approach do we know works? Play therapy. Therapeutic training is being launched by the government at the moment, and it provides us with the opening to explain why play therapy works and how we can all work together. Trauma Informed Schools website clearly explains the need for both therapeutic support for children and for earlier intervention, both points with which we are of course in full agreement. What stands out here is that the training being provided appears to be focused on mild to moderate referrals, whereas yet unclear as how this is assessed or where the threshold lies within the moderate band, but there is room for us to work together. The points that I hope we can explain to commissioners and ministers are the differences between creative therapies and talking therapies, that there is space for both. It might be that many children that a head teacher or a mental health leader planning to refer to a trauma-informed practitioner have already tried talking to, and it has been slow and difficult to effect change this way. although they are simply too young to talk through their experiences or to discuss and reflect on their behaviour and how it is linked to the trauma that they had suffered. In these cases, a play therapist to refer to would help. That trauma-informed practitioners work with mild to moderate referrals is well documented in the literature. This implies that they will need someone to refer more serious cases to that they cannot work with. Therapists trained to work up at the severe band of referral criteria. There's also the implication that these practitioners would need a therapist to refer on to if they discover a current case is more severe than first thought. And in both of these instances, a play therapy to refer to would help. Perhaps we need a triage system at the point of referral in a school, where referrals are considered together by the trauma-informed practitioner and the play therapist. Children might then be referred for a play therapy if they're either a moderate severe referral or very young, or if a creative therapy is thought to be the best choice. And children would be referred to the trauma-informed practitioner if they're a mild level referral, are able to talk through their experience and articulate well enough how they're feeling, and that they're old enough to engage with this model. This would create a collaborative, multidisciplinary approach, which the school could be very proud to house, and it could be copied elsewhere. Again, what helps is having a play therapist as part of the team to refer to. Lastly, these arguments fit with our lobbying of government, with the help of Dr. Lisa Cameron MP, to allocate some of its school-based mental health funding and post-pandemic help packages specifically to play therapy. We've been asking registrants to contact their MPs about this, and the briefing papers I send today should help you. I would imagine that any trauma-informed school promoter would be interested and motivated to understand how different practices could serve the whole school or a cluster of schools, as a model of best practice for the whole school approach, which is promoted in the government papers. Not only best practice to have choices of interventions across such a wide age range, but so as not to depend on statutory service for all moderate to severe referrals at a time when resources are so very strained. I do hope that we can lead explanations on these distinctions between models of work and the room and necessity for collaboration. All this in order to best meet the needs of our children and young people, many of whom so desperately need it. Thank you very much for listening. Goodbye.